NAMI-NYC. NAMI-NYC, the National Alliance on Mental Illness of New York City, is a grassroots mental health organization. We have an office in Manhattan, which is currently closed, unfortunately, but we do have services that we are offering remotely, and I'm going to talk a little bit more about that in a moment. We are really pleased to welcome Dr. Hale and Dr. Antoine to speak on treating depression, myths and misconceptions, and then the reality of what treating depression is like. Let me take a look, see if I'm missing anything. Yeah, so I'm going to talk a little bit about our services. NAMI-NYC provides support and education for anybody impacted by mental health issues, as well as their family members and friends. So we have support groups, classes, and other services offered free of charge and offered remotely right now. You can go to our website, NAMI-NYC.org, to find out more about those services. You can also call our helpline, 212-684-3264, or email us at helpline@NAMI-NYC.org. Our hours are Monday through Friday, 10 a.m. to 6 p.m. And we hope to hear from you. Yeah, we have all of our support groups and classes are peer-led. So those are facilitated by people with lived experience dealing with a mental health issue or with lived experience as a family member. So we hope to create a community and a space where people can talk about what they're dealing with, can talk about what is going on with them in a space with other people who have dealt with similar issues. So with that, I would like to introduce our speakers, Dr. Hale and Dr. Antoine. Dr. Antoine, Denis Antoine II, is duly board certified in psychiatry and addiction medicine. He is the director of the Cornerstone Clinic at Helping Up Mission program and the Addiction Treatment Services and Center for Addiction and Pregnancy Programs at the Johns Hopkins Bayview Medical Center. Dan Hale is a special advisor to the president of the Johns Hopkins Bayview Medical Center and director of the Healthy Community Partnership. So welcome. I do want to say that this program is made possible in part by a grant from the William S. Herper Foundation. And so with that, I'm going to turn it over to Dr. Hale and Dr. Antoine. Thank you both so much. And thank you to our audience for being here.
Thank you, Clara. Thanks to NAMI New York for having us as well. I think this is going to be a great opportunity to talk about a lot of different things. I think our main goal is to make sure we have the opportunity to have a combination of lived and professional experiences brought out to all the attendees here today, so we can talk more about what depression is, and maybe talk also about what misconceptions and maybe even stigma of depression that might come through. And just so that Dr. Hale and myself can bring a different perspective, and hopefully we can have the opportunity towards the end to get questions if we can, just to help clear up any ideas or concerns people have that are attending. As you mentioned, I work in a few areas in the Baltimore metropolitan area, and I'm a psychiatrist by training. But I've also been able to work in the addiction field for quite a while now, almost a decade and a half in Baltimore. And I've been able to work with a lot of different patients and clients in different settings. And I think it's a great opportunity to talk with someone who is not only a professional, who Dr. Hale is, but also has a lived experience. So I'm looking forward to having this conversation to learn from him and offer what I can to enhance what he brings to the table here. So Dr. Hale, you know, I've known each other for a little while, so it's good to be able to talk with you in this forum. Maybe you can talk a little bit about yourself and your professional background.
Sure. So thank you, Dr. Antoine, and thank you, Clara, for having us here today. Yes, I'm trained as a clinical psychologist. Began my training 40 some odd years ago. During that training, became very interested in mood disorders, particularly depression. I was sort of fascinated with it initially, and found that although it was a very challenging field to work with these individuals, is also very gratifying to be able to play a role helping them recover. So I practiced as a psychologist, as a psychotherapist for over 30 years. I've now moved into hospital administration, so I no longer have that practice. But as you will hear, that doesn't mean I haven't had more experience with depression, because it's hit me too.
And I know you've been at Hopkins for a while, and what I've noted in my interactions with you is that you have been fairly open about your personal experience with depression. And I remember you talking about maybe 2 episodes that you've had in the past. What was it like for you to make it through those experiences, those episodes?
So it was very difficult both times. It's the most painful, debilitating thing I've ever had to deal with. Perhaps it'd be helpful if I went through some of the symptoms, what it was actually like for me. And, you know, as a mental health professional, you and I both know that we typically talk about 9 or so key symptoms of depression. And since I don't do anything halfway, I can say I had them all, both times. And to sort of give you a sense of those symptoms and what they were like for me, the first is a deep, profound sense of sadness that was far deeper, more severe, more pervasive than anything I'd ever had before. I mean, I had certainly experienced sadness and disappointment, but this was very different. It was very similar to grief in many respects, but it also differed in some ways because where grief tends to sort of come in waves, this was with me every minute, every day. I had no relief, no reprieve from it. Another symptom was I lost the ability to enjoy anything in life. I mean, anything. I no longer enjoyed being with friends. I no longer enjoyed the activities I used to enjoy. I no longer enjoyed movies, books, TVs. I couldn't even feel, even when I saw or heard something that was clearly funny, I could say in my head, that's funny. I couldn't laugh. I just, the ability to experience joy was gone from my life. I also, part of the loss of interest was for food. Food was no longer appealing. Lost my appetite. I didn't feel like fixing good meals. I didn't feel like going out to or a restaurant where I might run into somebody. So I lost 10 or 12 pounds. Sometimes other people will gain weight, but it's also quite common to lose weight as I did. One of the worst symptoms was sleep disturbance. I'd always been someone who could sort of turn off the TV, put down the book, pull up the covers, and go off to sleep. Couldn't do that anymore. I was awake for another hour, hour and a half, terrible thoughts running through my head. Finally fall asleep, exhausted. But the worst part was I would wake up around 4:30 in the morning and not be able to go back to sleep. You know, my body wasn't rested, but it wouldn't let me go back to sleep. And so that was certainly literally one of the darkest moments of the depression. I was exhausted and I mean, just fatigued all the time. Things, little household tasks that I could do effortlessly before were overwhelming. And it was even part of the time, it was more than that, there was a sense of physical weakness. There were days I did not know if my legs would carry me across the room. I really felt that weak. I was slowed down. I couldn't move as fast, just didn't move as fast. I couldn't talk as fast. I also had trouble concentrating, you know, And as a professor and psychologist, I needed to be concentrating, focused. I couldn't maintain my focus, you know, to just go all the way down a page on a book or a magazine. I couldn't always, you know, remember what people told me because I had tuned them out unwittingly. I had tuned them out. And one of the, again, each of these is painful, but I'd always been a fairly confident person. With my first episode, I was well into my career. I'd been doing, you know, had my doctorate, had my degrees and my professional credentials at a university. But when the depression hit, I felt absolutely worthless. No self-esteem at all. It just completely bottomed out. I felt like a fraud, an imposter. And I was afraid I was going to be discovered. I was afraid I was going to go into the classroom sometime and with a 17-year-old freshman be asked a question I couldn't answer. And it would be discovered that I didn't deserve to be there at the university. And then there were the thoughts of death. Fortunately, I was never suicidal, but it was on my mind a lot. I was convinced that I would not live a long life. I just didn't expect to live much longer. So that's pretty much the picture of both episodes.
Yeah, and that's a tremendous experience to have gone through. And you know, you and I have known each other for a while to know that I think of, or I try to conceptualize a person's mood and depression almost like a song. I brought that up in different contexts. And oddly enough, and I think make it more familiar in talking about, there's a saying that Quincy Jones says that every song has the same 12 notes. They're just arranged in different ways. If you look at a piano, that's all there are. There are only 12 notes. And it sounds like you've had all the symptoms of depression. You know, professionally, I think we both know that, but I've always heard it rearranged in different ways depending on who I talk to. Appetite could vary, sleep could vary, how they feel can vary. So it sounds like your arrangement was very profound for you. But you know, keeping with that song theme, when did you first notice your song changing? Meaning, you know, when was there something that was linked to something changing in your life to say, oh, I'm feeling depressed? What did you first notice? Or what was going on?
Yeah, and that's a very important question. So the first episode of depression, well, I did not know of any depression in my family background. So as far as I knew, neither of my parents had been depressed. My sister had never been depressed. So in one sense, I wasn't expecting it. But it occurred at a very trying, difficult point in my life. My father had been ill. I had done some caregiving for him. He died. A year later, my mother died. Less than a year later, my marriage began to unravel, continued to unravel. And so the stress was overwhelming. But for all my training, and I think I was pretty well trained and pretty conversant in depression, I really, although there was all that stress, I didn't notice I had slipped and crossed a line somewhere. And it had gone from being highly stressed to being depressed. It was an insidious, slow decline. And it was actually a former student of mine who said, Dr. Hale, I think you might be depressed. And then, yes, I realized, yeah, you're right. I've been trying to sort of deny it. I've just sort of been thinking it's stress and I'll eventually get through this stress. And then I realized I couldn't get through it by myself.
And so once you realized that you needed assistance, what did treatment look like? Who did you go to for help?
Yeah, so I was fortunate, and I had worked with my primary care physician for a decade, and he knew me well. So I first went to him, and I said, Dr. Patel, I'm going to need a little extra time today, so let me sort of tell you what I've been going through. And I said, I'm pretty convinced I'm depressed, and want to start with you to see if what we should do, what you think we should do. He was comfortable with prescribing an antidepressant. This was back in the late 80s, so this was one of the first generation antidepressants that don't get used that much anymore. And so that felt good. It sort of gave me sort of a floor. I didn't really become happy and joyous, but my mood no longer sank quite as low. I was able to get pretty good night's sleep. It was a sedating antidepressant. And so that sort of gave me a sense of stability, but that wasn't enough because that did not control so many of the negative thoughts in my head. So I was thinking my career was going to be over. I was thinking that no one would ever want to be in a relationship with me again. You know, my thoughts about myself, about my world, about the future, they were all so dark and bleak. I just couldn't see things objectively. And I needed someone to help me see things more objectively. My problem solving abilities were shot. You know, just easy decisions that what should have been easy decisions were no longer easy decisions. And so I needed someone to really help me find some options and to think rationally again. So I sought out the help of a psychologist that I knew and trusted, and that was very helpful. The approach he took was one I was familiar with. I was trained pretty much in cognitive behavioral therapy. And so again, with all those thoughts that needed to be addressed, that was very helpful with the sort of changes I needed to incorporate in my life. Also blended in some interpersonal therapy because some of my difficulties came out of relationships. I needed to understand those better. And I was facing new challenges. I was now a single father. So those things were all part of that, as well as he helped me get on a path for self-care. I mean, you know, in my most lucid moments, and I did have a few of them, I would realize I need to make sure I get out of bed every morning, even if in other words, don't wait till I feel like getting out of bed. I need to know that get out of bed, and then my mood will probably increase a little bit. Eat my breakfast, go for a walk. So he really helped me develop and maintain a healthy routine. So I think it was really medication, which I would say was necessary, therapy, which was necessary, and then the self-care was a part of it too.
And so it sounds like you got a lot better with that combination, which I commonly see. I see that there's a need for not just the medication. It's not all about the medication. It's about, you know, adding more supportive treatments, supplemental treatments like cognitive behavioral therapy and interpersonal therapy. Did that sustain you? Did that sustain your mood for a long period of time, or was there a point at which things started to change again?
So it was a gradual improvement in my mood and my energy. I would guess it was somewhere around by 6 months. So the medication, and of course you know this much better than I do, but the medication didn't work instantly. Most antidepressants don't. Fortunately, I knew that. I need to have patience. And so I was probably getting, so one, and this was important to me, I'd heard it from my patients before, just being able to sort of hand over my problems to someone else and say, you're the expert. I'm just going to be the patient here. You're the expert. One, there was a sense of relief. And then, and my growing confidence. And then the sort of, again, the mood came some with the medication. And then I was beginning solving problems. So within, probably 6 to 8 weeks, I was feeling pretty confident. Maybe by 3 or 4 weeks, I was feeling I'm on the right path. By 6 to 8 weeks, I was feeling like, yeah, this is working. And a few more months. So I would say 6 months out, I was pretty much back. I was ready to sort of be back feeling good, maybe 90% where I'd been before. And then so that lasted. I mean, it went on to 100%.
There you go.
It went on to 100%. And and so this was 1988. You want me to just go ahead and talk about that, or were there any questions about that? Sort of?
I do have a couple questions. I mean, it is always great to see that steady increase and that rise. Along the way, Was it always linear, or were there any setbacks? I'm curious about that. Yeah, or was it just a straight elevation to where you wanted to be?
No, I mean, it was largely that, but there were the occasional setbacks because there were still challenges that were going on in my life. And there were times I, wasn't at my best. There were times, I think always lurking in the background was, depression might come back. Maybe I wasn't going to make it all. So it was largely upwards, no deep dips, but there were some setbacks along the way.
Right, and I see that a lot with individuals I work with, and even some of my family members as well who have depression. And it is something where it sounds like the therapy was a great support at those times to sustain you in the direction that you wanted to go.
Yes.
It's really good to hear that you had that combination available. Not everyone uses that combination, so I'm glad it was good for you. And so still though, I heard there was a second episode.
Yeah.
And what was going on at that time in your life when that episode started?
Yeah, and so the symptoms were the same, or some might say, but more severe. What was surprising was I would have said, this was 2005. So, 17 years later, I would have told you my life was going very well. Professionally, I had made it to the top rank at my university. I had published a couple books. I had presented at conferences. I was being invited to speak at medical centers and at universities. I felt good about myself. I had been very fortunate to meet, fall in love with, and marry a wonderful woman who is now there in my life. So if you would have said, how is life going? I would have said, it's great. But I can't, thinking back, I can't identify when the depression came, but there certainly was no obvious trigger to it. But all those symptoms I mentioned before came back, and it was a scary time.
And treatment-wise, what did you do this time? Was it the same family practitioner or the physician that you went to, or did you take a different approach?
Yeah, so I tried a similar approach, but so my longtime physician was on an extended vacation out of the country. There was no way to reach him. He had someone covering for his practice, another internal medicine doc, and I went to him. And I think this was, and perhaps you can elaborate on this. I had heard about this time somewhere around 2000 that many general practitioners or family practice or internal medicine docs, they become comfortable with 2 or 3 antidepressants, and they try those. And if those don't work, then you need to go somewhere else. And that was sort of my experience. Okay. This physician felt most comfortable with a couple of the SSRIs. He tried me on one. It did nothing to help the depression, and in fact created anxiety like I had never really had. I know sometimes, anxiety certainly can be a part of depression, but largely that hadn't been my case. And now anxiety was coming into my life. And again, he tried both of those, and then said, I think it's time for a specialist. And I was fortunate, even though I was in Florida, I had been working with some of your colleagues up here and reached out to them, and they found me a wonderful psychiatrist, Hopkins-trained psychiatrist, but who was practicing in another city in Florida. It was probably two hours away, but I said, I will do anything. So I drove over, met with her, did really good assessment, and prescribed a very different type antidepressant. And it just, the way she said she hoped it would work, and it did, it just sort of smoothed me out. And the anxiety went away, and I felt stable again, and I felt, and I could get good sleep. If I can get a good night's sleep, that's worth an awful lot to me. And so that was, I would have to say that the medication was the major healing factor for me. I did go see a psychologist again because my confidence went down. My confidence, I think two things I experienced was, I didn't feel like I was the person I was before completely. I wasn't all the way back just because of the medication. And also, I felt very guilty, for being a burden to my wife, who never said anything to make me feel that way. But, part of my depressive mindset is just the smallest thing, I can turn it into something big and sort of ignore the positives and focus on the negatives and let them explode. So I really needed some help with that.
And I'm curious about two things from that. One, it sounds like your wife was a key support figure in your life. Did you have a large support network, or any others, or any other places that might have been just as supportive?
I did, and I was more open. I mean, I didn't go around telling everybody, but what I discovered as I became a little more open about it was how many other people, senior professors with endowed professorships and, so forth, they've been there too. And you're sort of a member of a distinguished club in some ways. And one of the most distinguished professors, you were talking about music earlier, the dean of the music school at my university, had been sort of a friend, and he just sort of said, I'm going to take you to lunch Friday, even though I didn't feel like I deserved the attention of this distinguished professor, and I have no musical talent, so there was no reason for him to have any real interest in my life. And he said, I'm going to pick you up every Friday. And every Friday we went to lunch, and he listened to me, and he never tried to, he basically listened. And he never really tried to say, Dan, that's silly, of course, this. But he found ways to just sort of interject here and there. You're respected by your colleagues. I hear from your students. They really like you. And that sort of gradually built that up. And that reminded me, though, of something I've left out before. When I went to the therapist, who was also cognitively oriented, for the second time, and I was convinced that my course evaluations were going to be in the toilet. And instead of just sort of saying, "Oh, I'm sure that's fine," he said, "Well, let's do an experiment. Let's gather some data." And I did, and I found out I was still doing well in the classroom, but it took that objective data to actually convince me. So, but yes, that's one example of the dean, and there were others. Some from my church. Church has been an important part of my life, and there were those there who understood and who, they gave me a lot of love. Mm-hmm. No one I was dealing with my support system thought that love would be enough. Mm. They sure thought it was a helpful aid, and it was.
Understood. And yeah, support always comes through as one of those themes of every song I've heard. The better the support, the better the outcomes, and just as important, if not more important, than the medication sometimes. But the second part I was wondering about, with the medication, how long did you stay on it this time, or the second time?
Okay. Yeah, and I'm glad you asked that, because I know from my professional experience how so many patients I would see, when I would encourage them to consider medication being a part of their treatment, and when they did go get some antidepressant medication, they always seem to be in a hurry to get off it. Like, that's the measure of success is how fast can I get off the medication. But I knew from being in the field that you don't want to stop medication just because all your symptoms are gone. I mean, I know the evidence, I believe in the evidence, which is, you need to stay on it 6, maybe 12 months after an episode. But when I had so I'd done that the first time, and that was wise. This time, and I discussed it with a psychiatrist, said, what do you think about how long you should stay on it? And, she, made sure that it would not interact in a negative way with any of my other medications or any of my other health issues, and suggested that I stay on it indefinitely. And it was an easy sell. And I know some people resist, but to me, the idea of, I take my cholesterol medication every night, and I take my mirtazapine every night. And to me, both of those are smart moves to make. So this is 15 years later, I still take it, and I imagine that I'll take it the rest of my life. And to me, the measure of success is I have the energy to, come into work first thing in the morning, stay late if I need to, go home, exercise, enjoy my wife. Why risk another episode of depression?
Yeah, that makes a lot of sense. And had you considered any other types of treatments? I work in a hospital frequently where I see patients. Is that something that came to mind in that process?
So to be honest, yes. So when that second episode, which, like I said, was worse than the first episode and was scary, and I've used that term a couple of times. I mean, I really got frightened about, even though I didn't have any suicidal intent, I still felt so fragile, so frail, that I was very worried about myself. So when I talked to my colleague, him, Dr. Bennett, not a psychiatrist, a geriatrician, and talked to him, and once they found me the psychiatrist in Florida, but he also said, that doesn't work. Get on a plane and come up here, and we'll check you into the Johns Hopkins Hospital. And I said, that's exactly what I'll do. And we discussed what treatments might be a part of that. And one that I hope you'll elaborate on, because I didn't go that route, but it's one that I was willing to go the route. And I have no hesitation saying if I were to be seriously depressed again and the medication and therapy didn't work, I would go this route. And that was ECT. I've had patients who have just come back to life from that when nothing else worked. So I've heard it firsthand and I've seen the evidence. But I think there's a lot of resistance, but I considered it. And I was fortunate I didn't need to, but do you mind if I sort of turn the interview around and ask you, what do you think about ECT?
It's one of those where if you were just to watch the movies where it's included, I don't think it's necessarily portrayed well. And I let off saying that there's stigma out there about depression and treatment. And that's the classic. One Flew Over the Cuckoo's Nest is the classic movie. And it may have been accurate at some times, but it's been a lasting image that unfortunately doesn't do it justice, to electric compulsive therapy justice. At this point, I've sent many patients to ECT in the past and seen it do wonders for their mood. But it's not used as quickly as an antidepressant as it should not be. Usually hospitalizations and ECT, from my standpoint, are for points where people are really at their lowest and can't get out of bed, can't eat. And I've had to try to feed people for days at a time because they're not feeding themselves. That's when we think about ECT. You tried multiple depression medications and it's just not working. You say, this is something we need to start the process a little bit faster. So that's when we would start it, and not any sooner. If anyone thinks of it sooner, it probably would not be appropriate. However, in terms of the effects, it is very effective, and it's a lot safer than it was done back when those movies were made. In the past, there were bad stories about how it was conducted and bad outcomes, but now you're really working in a team that's very close to a surgical suite. You have anesthesiologists, different doctors, different types of monitoring to make it safer. And I think that is a critical thing to bring up, that the safety of those types of medications are being looked at a lot closer, and ECT is one that is safer. And then there are going to be some subsequent treatments like cranial magnetic stimulation, which essentially are magnets that will make that same electrical current and treat the brain the same way. So it would be even safer. Instead of having to use electricity, you just use magnets to create that same effect. So I think that is what we have in our arsenal right now that's approved for depression. But in the hospital sense, and I see Jay Wolf asking this question in the chat, in the background, people are trying to consider what is possible about other treatments. And ketamine is just not one that's approved yet, but it's one that people are exploring for sure to see if it's a viable, approvable option for that depth of depression. But it shouldn't be to a point where those are the first line, and it certainly doesn't replace the support that you talked about, Dr. Hale, and also making sure that you're getting into therapy to address those other issues that might be lingering in the background. So that's a great question there. I'll stay on this side of the conversation in terms of what other questions do you have for me, or any questions you have for me that you might think of. I see some in the chat box, but how about yourself? Anything else come to mind?
So I think I'd like to get your take on advice you give family members, because I think from my own experience, but I think it's very difficult to live with somebody who's in the midst of a very serious depression, even if they're on the sort of road to recovery.
Right.
And so what role do you see for family, and what advice do you give them?
Yeah, no, it is one, I always say, do you have the support that you need for yourself? That's a critical piece, because it can be a foreign experience. And I think NAMI is a tremendous resource to make sure that the family is understanding what's going on. And because without their ability to support the person who's going through the depressive episode, it will be difficult. So that's a common staple. Number two, when it comes to the person themselves who's going through the depression, it really seems critical to make sure you value that person as an individual, because it is something that they're going through, and it's not a personal thing that they're trying to take out on you as the person who's the support. So keeping that in mind, it's almost like hate the sin, but don't hate the sinner. There's still a person who's going through the situation, and recognize that it may be difficult, but sometimes you have to take a step back to support yourself. And if it's too much, takes too much of a toll on you, you have to recognize that and practice that self-care for yourself. But being patient as well. There may be resistance along the way. There likely is resistance along the way, because as you pointed out, sometimes you aren't quite aware, the person isn't quite aware that it's depression that's happening. Maybe they think it's something else. So being able to roll with that resistance is very critical. But always support for the supporter is key.
I know we want to allow for other questions, but I have one more I want to ask about, particularly on that, what I think is not only stressful, but really just scary for a family member if you think your loved one might be suicidal. What advice do you have for someone who is living or knows someone closely who you fear might be suicidal?
Yeah, I would say, one, it doesn't worsen the situation to ask directly, because you want to make sure that you're aware of what's going on and aware of the risks, and try to find ways to help out with those risks. So we often think about what is in the house that might be a potential, tool for that process if they're thinking about suicide. So asking, are you thinking about suicide? Is there any plan that you have? Is there any way I can help? And then thinking of getting some of the potentially dangerous items or substances out of harm's way, locking them up, taking knives out of the house. We commonly advise people to do that if there's a thought process going through a person's head. So just getting to that myth that asking makes the thoughts worse. That's not always the case. Sometimes it's helpful for a person to be checked in on, and that way they know there's someone who's worried about them and thinking about them.
I think we wanted to leave at least a half hour for questions from the others. So Clara, are you going to take over now to monitor this, or?
Yeah, so there's a couple of questions that have come up in the chat. So I'm not going to go in order, so I'm going to jump around a little bit. But one question that I think is great just to start off the bat is, you know, we've talked, a lot of the discussion has been, especially Dr. Hale, what you mentioned is talking about depression that is really recognizable as a distinct feeling from your normal state of being. And someone in the chat asked about, do you have additional or different recommendations for someone who experiences depression as more of an ongoing state rather than something that sort of one goes into and comes out of in like distinct episodes?
I can jump on that one if you want, Dr. Hale. Yeah, I think the word depression is sometimes used interchangeably with major depressive disorder, and that's something to break up a little bit and distinguish between the two. Major depressive disorder is what Dr. Hale was talking about, and those distinct symptoms are part of the biological aspect of what goes into a major depressive episode, and that's a treatable condition for certain. I think along with that or next to that, but somewhat separate from that, is depression. And sometimes people call it big D versus little d. And the long-term symptoms would be, something that should be addressed in something like therapy and increasing support to see what might be leading to that enduring chronic set of feelings that a person feels depressed. But if it is that long, there's often a separate issue or set of issues that's going on that needs to be addressed with that probably life story approach, we would call it, and seeing if there's a way to change the setting and the sequence where a person is in order to get a different outcome with how they're feeling. And that's different from the biological depression, which has a clear etiology in the brain and with neurotransmitters that can be adjusted with treatment through medication and possibly those higher level treatments, ECT and others. So that would be my suggestion, to maybe seek some type of therapy there to see what is the underlying setting and sequence that could be adjusted.
Great, yeah, thank you. Sort of going off of that, can you talk a little bit more about, I think this was addressed in terms of ACT and ECT and the different treatments that you have both spoken about, but can you elaborate a little bit on the path for someone who is very clear that they do not want to take medication for depression? There have been a couple of questions about that.
Yeah, I see that very, very, very often. I work in an area where there isn't a high uptake of medications. People are not often interested, but they come for other things. And they, I mentioned that the song is something you want to focus on, and medication is not the only part of the song and shouldn't always be the other part of the song. So it comes down to what is the person up for? Is it support? Is it going to church? Is it going to different games and getting into activities to get that routine back? Is it going to therapy every week? So I think it comes down to what are the helpful things that can be supportive of a person's mood. But then also coming back to say, hey, we tried this. Is it working? If it is working, great. I would go back to that person and say, what if it doesn't work? What should we do next? And just having that backup plan, because I think the goal is always to get a person's mood better, and the goal is always to work in a way that's meaningful to that person so that you can move forward. But the reality is, if it's helpful, great. But if it's not, there should also be a plan to establish that goal and meet that goal for the individual.
And I agree. I mean, I I was in a community, small community, where we didn't have a psychiatrist for a while. So I ended up seeing some very seriously depressed individuals. And then there were some that just simply wanted to go first try the route of no medication. And so, psychotherapy can be very effective with certainly mild to moderate depression, not the vegetative type where, like you were saying earlier, somebody needs to even be fed.
Mm-hmm.
But a good therapist who has the training and experience working with mood disorders, if somebody wants to go that route for a while, I would certainly be comfortable with that.
Another question, which I think is really poignant. I struggle with guilt for not seeking and receiving treatment earlier. How can I overcome that? That's a question from the chat.
It's a good question, and it sounds like, and if I'm hearing it correctly, it sounds like whoever's asking is currently in treatment and in
Yeah.
therapy, which is great. I think that's the key place to decompress a lot of that. I think part of the focus should be, though, on what is getting better. What things have returned, what things have you been able to accomplish just by going into treatment, because not everyone goes to treatment. And I think making that tremendous step should be something that deserves some self-praise just right there. So not focusing, I think I'm a sucker for metaphors and for sayings, but you run to the light, not away from the darkness. You don't think about what you didn't do or how you didn't do it before. I think it's a tremendous thing that you're doing it now, and trying to optimize that and use that experience to grow and bring other people to support you through that. I think that's the focus to go on.
Yeah, absolutely. Another question, and there was a question earlier in the chat about stigma around seeking treatment that was sort of culturally specific. And I think this question that I'm going to read now kind of maybe speaks to that question a bit. I feel I've been depressed for a very long time, but my diagnosis for a very long time has been psychosis. Research does show that Black people are more likely to be diagnosed with psychosis and less likely to be diagnosed with mood disorders. How can I adequately explain to my treater, my treatment team, that I feel I'm misdiagnosed?
That's an excellent question. Dr. Hale knows that I speak to this topic specifically at different points where I'm located, and just to I guess recall the literature that I'm aware of. There is a long literature of African Americans being misdiagnosed with schizophrenia versus what they truly may have as depression. Where famous people have gone through that, and I think there is also a stigma based on that and some other historical aspects of the psychiatric field where people may be hesitant to go to treatment. So once again, I'm congratulating you for even stepping into the treatment realm. That's a huge step. I think there's an opportunity there to ask your practitioner to be objective with the measurements. And that might be a helpful way to go about it. If you are concerned, ask your practitioner, are there objective standardized tools that we can track over time for psychosis versus depression? And that would help show that practitioner, oh, maybe I should be looking in this direction instead. And try to have a joint plan to say, I want to find the best way to treat what I have that's going on and work with you, practitioner X, to do that. But I feel like using objective measures is the way that those misdiagnoses were discovered in the literature, and a good way for you to work with your practitioner to move past any misconceptions that might be used right now.
Absolutely. Question from a little while back about talking about mental illness in general, but especially depression with children. How is there a way that you recommend speaking to children about depression, and what does that kind of look like?
Right. And I think the song for children is different than adults. That's the first thing to recognize. There's There's going to be a different presentation, and it is very much compounded by social media and the internet, and what images they get. So I think the setting is really important to focus on, and see what happens when you bring the child or the adolescent, or the college student to a different setting, and try to see if that's something that's helpful. That could be a way to support. Medications are going to be a different tale there as well, because there's often a higher, not resistance, but a higher concern from a child about taking medications, because if they feel like it might control their lives. So being supportive and even more patient with the child is going to be very key. But I think the setting is going to be just as important to figure out how you can be supportive, because often that can be a triggering factor for that age.
Dr. Hale, I can't tell if you're thinking about your response or if you're leaving that to Dr. Antoine. That's fine. Oh, so this is an interesting question. What about people who are in denial of their mental health issues? I'm not sure if this is referring to mental health issues for themselves or mental health issues in general, but I assume it's mental health issues in themselves because they are successful by external societal standards. Can you talk a little bit about the interplay there?
That's a good one. That's a good one. I think we talk about it in my institution, such as the ABCs of behavior, the antecedents, behaviors, and the consequences. And not to say that depression is a behavior or mental illness is a behavior at all, but often it is hard to have a conversation about what might be affecting someone if there isn't a consequence. But at the same time, if a person would like more out of their life, and they have a goal that they're not quite meeting, not necessarily on the job, but maybe a relationship or something that is a social difficulty, then there's an opportunity to have a conversation. But I would say one of the definitions of, I'd say, a mental illness is social difficulty affecting their social life, their social standing, and their ability to function. So I would say, hey, make sure you check in with that individual to see where might they be struggling, because it may not be the job, it may not be as a parent as well. As Dr. Hale talked about, many individuals in academic institutions might do well on their job and have high profile function, but it's about learning all of their life and really just getting to know them. And eventually, you might find that there's something that they're struggling with, and that is that opportunity then to say, well, I'd love to help you with it if you'd like. And that's just a suggested way to go about it.
I would just add on to that. I've had situations where I didn't think it was worth trying to get into an argument over, are they diagnosably depressed?
Mm-hmm.
But they're hurting in some way.
Mm-hmm.
And so, it could be something like, I just not getting any sleep. And then be saying other things too that you'd say, well, it sounds like depression. But, to simply say, well, talk to your doctor about the symptoms and see if there's some medication that can help with the symptoms so that you can feel better. And again, do you have clinical or major depression? We don't have to clarify that.
Right.
Get some help.
I completely agree with that. Yeah, we do spend a lot of time, and this is me as a psychiatrist saying it, we spend a lot of time talking about what is the diagnosis, but it's more so to me, where can I help? How can I help you today? And sometimes it's just making sure you have a bus token, but sometimes it is medication. You got to find the right place and right place to get that help.
A follow-up question to about talking about depression with children. Do you have any recommendations for talking to children if a parent is struggling with depression or bipolar disorder or another mental health issue? So presumably, one parent explaining to a child about their own struggles or and the other parent's struggles, what that might look like.
I think it's an opportunity to bring up some of the points here that, this is a treatable condition, and make sure that the child understands that, this is something that, the mother, father, whatever parental figure is going through, but they're working through it in time, and however they can be supportive is key. And that's where family therapy also comes into play during some of those situations, to say, let's come together as a family, because addressing the individual doesn't always solve the unit, and that's also a key aspect to address. So I think family therapy could also be considered in addition to the individual types of therapy Dr. Hale mentioned.
I would just add that I come from a background where 20, 30 years ago, among psychologists, there was a lot of resistance to sort of the medical model. And we really wanted to say, I can understand. I appreciate it. I understood it completely then and now. But I feel it's much better to go ahead and talk about this as an illness. And to say, your mother, your father has this illness, and it's probably going to affect, his or her energy with you, or maybe even some things they might say sometimes. But, he are getting help. But, we all have illnesses from time to time, and this is an illness that is impacting her, and in terms, or him, and in turn it impacts others. So you hear me now. I think 30 years ago, I didn't talk about illness, disease so much when I talked about depression. I'm very comfortable and prefer talking about it as a terrible illness, a terrible disease. It's a medical issue. It's not a moral issue. It's not a religious issue. So.
Fully agreed.
Sorry, I'm jumping around. Well, this is an interesting question. I'm not sure actually this person meant this to be a general question, but I think it's an interesting question. Can you talk about the intersection of depression and sort of basic physical habits like eating, nutrition, sleep, how that, I think particularly eating and nutrition, talk a little bit about that, physical wellness.
Yeah, I can jump on that one. I would say the brain is responsible for monitoring and moderating how we function in daily life. And we take for granted some of those things. Some things we don't take for granted, how to point. We know that the brain controls the motor function, and, the eyes are the window to how we interpret what we see. But it affects other things. It regulates our pattern of sleep. So we know when to fall asleep and know when to wake up a little bit as well, and our energy. But there are also certain parts of the brain that are responsible for how we taste things, how we smell things, and how we are satiated, I would say, or know when we're full. And the body regulates all of that. So when the brain, especially in certain areas, are not working well, and that's what happens in depression, those parts of the brain are also not working well. So you actually don't taste as well. You don't smell as well. Your appetite can go down, and depending on certain variations, your appetite can go up, and your sleep as well. So it's also why certain medical conditions can mimic those types of symptoms, because the brain may not be getting as much blood flow or nutrition, which would allow for normal function. So that's where those things go off. And nutrition is very important, because certain vitamins and nutrients allow your brain to get the proper blood flow and nutrition to keep thinking properly, and also with taste and other things. So nutrition can play a large role, not always the sole role, but a large role in keeping a person on track.
I think another part is that if you look at chronic conditions that require a lot of regular monitoring and management, that falls on the shoulders of the patient themselves. When you're depressed, you just don't, that's just not a high priority to be fixing a good meal and to getting exercise and so forth. So those things that your cardiologist might prescribe or your endocrinologist might prescribe, yeah, those sound good, but boy, when you're depressed, that's like you're asking me to climb a mountain.
That's right.
Absolutely. Question about medication side effects. Are there can medication cause other disorders to develop that then have to be addressed? Like, what's this question? If the person who submitted that question could maybe clarify a little bit, but I think that the question is about side effects for medication and how to sort of mitigate those.
I think that's an individualized conversation.
Yeah.
Part of it though is there are always side effects that we talk about when prescribing them, just to make sure people are aware. With SSRI, sexual side effects comes up often, and we have ways of working through that with different classes of medications that don't have those sexual side effects, but are still as effective for depression. And sometimes side effects are good. Sleep can be a side effect of certain medications, and you use that to help with, getting that energy that you need. So it really depends on what effect you're looking for. Also, certain medications increase appetite, which, depending on what's happening with depression, is also good. So I would say there is a potential for certain medications to be difficult. Sexual side effects is commonly one that comes up. Another could be dry mouth or dizziness, depending on how fast the medications are changed. But it really comes down to working with the individual prescriber, whether it's a psychiatrist or another type of physician, to make sure you're having that communication and saying, well, this is coming up. What can we do to make that adjustment to make you more comfortable? But Dr. Hale, I don't know if you had any other advice based off of your experience.
Yeah, I was just going to say that it is so important to stay in regular contact with your provider, not to simply say, well, the medication is not working or the medication is having these bad side effects. You need to share that because there are so many good options, options for other antidepressants within that same class and options of different classes. So often, you can, like you were saying, find a medication that doesn't have this bothersome side effect. But don't just give up.
Right. Yeah, I think in the 80s, there was a limited supply of medications, and a lot of those medications had different side effects that were difficult to get away from. But there has been a parsing out of so many different types of molecules that side effects can be avoidable now.
Oh, I guess there is a follow-up, which is whether it's, so the question is, if it's true that there may be some long-term effects on cognition because from antidepressants, or particularly SSRIs, and is that something that either of you have particular concerns about?
Yeah, well, actually, the evidence that's come out when people have done brain imaging for treatment on SSRIs is that there's a certain part of the brain called the hippocampus, and that's the bottom part of the brain. And in long-term imaging of the brain, what you see is when a person's depressed, that part of the brain can be a little bit shrunken and decreased in size, which we think is highly correlated to depressive symptoms. And as you are in treatment longer, that brain size starts to restore itself. And you see an improvement there. So if you ask about what the cognitive effects are, you see improvement long-term in the effects and ability to concentrate better and other parts. So yes to the effects, but they are positive.
Thank you. That's very helpful. Question from a parent. How can family members in general, but I think especially parents, deal with the anxiety of having a family member that may be really struggling and feeling the need to sort of take drastic action, calling 911 or things like that, if they know that their family member is struggling?
I think support is a good place to start. Making sure that there are multiple people to bounce those ideas off of. And I guess a shout out to NAMI again, that is a thing that is out there to say, who else has gone through this? What other options are available before, because I would say calling the police and calling 911 has a lot of societal stress on that, especially during the days that we've gone through. So in order to not necessarily have to jump to that right away, I would say making sure you have people to talk through and say, hey, this is what's going on. What do you think? Having a good connection, if there is a provider in the picture saying this is what's going on, are there any options that we can think about for treatment as well? So you're not on your own. I find that family support is a big piece to help whomever the individual is who's trying to intervene. But that would be the starting point. I don't know, Dr. Hale, if you have any additional thoughts on that.
I agree. I mean, I think you need your own support system when you're dealing with a family member and someone that can help you see things more clearly and think of options. I would also just toss in and I'm sure NAMI has the relays this information, but the National Suicide Prevention Lifeline. You don't have to be suicidal to call that lifeline, and it's there 24 hours a day. So if you're struggling, not certain what you should do with this person, that's one source you can turn to for a little bit of help in the moment.
Absolutely. I think great. So something that's come up a lot, a couple of times in the chat, is the difficulty of accessing care, especially with, and I see you both nodding, right? This is something that comes up over and over again. There were a couple of questions, but one, I think in general, I think folks would love to know what you think are the most important changes to advocate for in terms of making care more accessible. How can people access care if they're not able to find someone who takes their insurance, if they're not insured? What do you think is most important to advocate for there?
I think the way the system works right now is a lot of these are state bound in terms of how insurance coverage occurs. I know in the state of Maryland, what we're trying to make sure of is that telehealth is something that's covered by the insurance companies that cover Medicaid and other persons who may have difficulty getting insurance. But from the New York, New York advice, I think the thing to advocate for would be that the health department get enough staffing for persons who might not be insured. So there can be a way of engaging in treatment in those areas, but also set up grants, hopefully, that would fund places that would be able to do sliding scale type facilities, support those facilities in the areas, because I know that's a large need. Insurance is not always a viable option for every individual, but going through those types of facilities in New York, I think would be the best thing to lobby for right now, in addition to making sure that telehealth options are more available so people don't have to travel as far, especially with the winter months coming. Telehealth is going to be a vital aspect to consider and utilize more, but that requires more resources, and I know that's not always a viable option.
I agree.
Absolutely. Well, we are coming to our close. I think there's some great conversation happening in the chat. I'm really glad we were able to kind of get that up and running. I'm trying to see, are there any last questions that people, you think we can do maybe one more question if somebody really feels like their point hasn't been addressed? Please feel free to throw that in the chat, and then we'll wrap it up. I'm sure that there were things, there's a lot of folks here and a lot of stuff happening in the chat, so there may have been things I missed, so please feel free to put your question back in if you feel like we haven't touched on it yet. I want to thank everyone for staying with us, and even through that rather upsetting beginning. I'm really glad we were able to keep this going and get this information to you all. Oh, okay, great. One last question to finish up, which I think is an important one to address. What advice would you offer to families of those who utilize alcohol or substances as self-medication?
He's the man that can answer this one.
Yeah, so yeah, the majority of my practice has to do with individuals who use substances and have co-occurring depression or other mental health issues. I would say one, don't wag your finger. I think that'd be the first thing. You will get a resistant response pretty quickly if you say, just don't do that and stop doing that. I think the key piece is to say, one, you're someone I care about, because that's the message they need to hear first, and be that support. Number two, see if there's something that can be as reinforcing or pleasurable that might compete with that substance, because often a person ends up using that because that might be the only thing that helps them in that moment. So that's just an alternate way of saying, how can we get you away from this? Maybe replace it with something just as reinforcing. Sometimes that requires saying, hey, can we spend a couple weeks in this facility? But don't expect that to be the quickest response, because there's often a lot going on and people don't want to drop everything, understandably, and go for that support. So then I would just make sure you do understand the song. Just, it's a good way to wrap up. Just say, what's been going on with that person. What has led them to the point where they, how did it get to this? How did it get to this? Because it didn't just start out that way, and there's probably a bigger story that needs to be understood. And if you do have that understanding, then you'll have a shot of saying, well, I understand where you're coming from. Maybe let's think of some ways together that we can help that out. But just come from a point of caring and saying, I just want you to feel better, and feel better in a way where you're going to be around to feel better for a long time.
I think that's a beautiful note to end on. Thank you all so much. Thank you to our audience members. Thank you to Dr. Hale and Dr. Antoine for sharing your expertise with us. If I put this in the chat, but if anyone has follow-up questions, I'm available at CKIELY@NAMI-NYC.org. Our helpline is also open until 6 p.m. today. So you can feel free to reach out there, 212-684-3264. And thank you again. Thank you for joining us. And I hope that everyone has a really great rest of their day.
Thank you, Clara.
Thank you, Clara.
Thank you.
All right. Have a good one.
Oh, and a question about the recording. That will be available on our Facebook page as well, right after the event, and on our YouTube channel in a little while. So thank you.
Thank you.
If you'd like to share it, please feel free.